Thank you, Dr. Vikas, for the introduction, and good morning to all of you. So you have seen a spectrum of melanotic conjunctival tumors by Dr. Vikas, which almost covers a large spectrum of surface tumors in the conjunctiva. So I'm going to touch upon on melanotic lesions, which is not many, and it's not difficult to diagnose. The only thing which is important is you need to differentiate these benign lesions from the malignant lesions, because the prognosis of bad malignant lesions, which is melanotic, is really worse. I have no financial disclosures, but I am affiliated with few other hospitals and institutes other than mine. So let's take this quiz here, the first. So I have these lesions A, B, C, D, E, and F. Can you help me find which is benign and which is malignant? Is A benign or malignant? What do you think? It is pigmented over here. Bulbar conjunctiva towards the limbus. Yes or no? Okay, or tell me which are the benign ones and which are the malignant ones. We will discuss about all these things later. A, yes or no? No. Benign, okay, all right. B, benign, I can see someone telling me benign, yes. C, benign? So, intermediate, someone told me intermediate. D, malignant. E, malignant. F, yeah? Okay. Benign. F is benign. F is benign, malignant, benign, benign. Right? Perfect. So we're going here now. So you all know the spectrum of benign melanocytic tumors: conjunctival nevus, racial melanosis, which is now respectively called as conjunctival complexion-associated melanosis, congenital ocular melanosis, primary acquired melanosis, and malignant is conjunctival melanoma. So what would you think this is? He's a 50-year-old gentleman with scattered lesions all over the conjunctiva, the bulbar conjunctiva, mainly concentrated along the limbus. Benign, of course, all right? So this is what we call as complexion-associated melanosis. Usually in this pigmented population, even I have few over my conjunctiva. We find it a lot in the pigmented population, like Indians, Asians, and Africans. So as your skin is pigmented, your conjunctiva also gets these scattered pigmentation. Usually it is bilateral. You see it symmetrically bilateral, all right? And they are variable pigmentation. They won't be having any uniformity. It's usually peri-bulbar conjunctiva and even extending a little bit into the cornea. So this is again a complexion-associated melanosis, right? Yeah. So now I'm going to show you, this is his left eye. I'm going to show you the right eye. Does it look as a complexion-associated melanosis? It doesn't, right? Yeah. Usually the complexion-associated melanosis is symmetric and it's bilateral, but this is kind of very asymmetric. Okay, so whenever there is an asymmetric complexion-associated melanosis that comes into your practice, you should always take a biopsy. Okay, so it could have been a primary acquired melanosis. In this case, the conjunctival lesions are so pigmented, they could also be a hiding melanoma in the primary acquired melanosis in this situation. So this was a primary acquired melanosis. You can see the atypical cells with severe atypia. All right. So this turned out to be an asymmetric pigmentation, a primary acquired melanosis in the right eye. An easy one. A pigmented lesion, well defined in the bulbar conjunctiva. Okay, variable pigmentation all around. And what is these striking lesions over the surface over here? Cysts, okay? What does that indicate? Benign lesion, specifically? nevus. All right, so the characteristic feature of nevus is it will be in the bulbar conjunctiva, it will be having variable pigmentation and these micro and the macro cysts. So whenever you are in doubt whether it's a conjunctival melanoma or a nevus, obviously the age of presentation will help you, and the presence of this cyst is a big clue in these. So we always talk about these malignant lesion and relate it to the feeder vessels. You know, whenever Dr. Vikas has given you a very good overview about these and the characteristic features which would help you to differentiate a malignant lesion from a benign lesion, we always talk about feeder vessels. We do find, you know, like in 64% of even conjunctival nevus, so that the nevus can grow, you can see a sudden spurt of these lesions where the parents comes back to you in a, you know, a child in the pubertal age. They comes back to you and tell you like, well, I have seen a sudden growth in the lesion. It's common, all right? So these are the feeder vessels which enhances the growth of this lesion due to hormonal changes in the body. All right, so usually it's unilateral, but there are occasionally and very rarely nevus can happen bilaterally also. So this is a patient who has bilateral nevus. So these are all, you know, it's slightly melanotic and thickened over here, and that's exactly why I did a biopsy in her and it has been confirmed as a nevus. She has a large cystic bullous lesion over here. I'm going to show you a closer picture. This is not totally melanotic, so you do have a melanotic conjunctival nevus also, but then you can get a clue from the scattered pigmentation that you see over here. Okay, so this is a case of bilateral nevus. So how does anterior segment OCT applicable in these lesions are? Whenever you are in doubt, you can do an ASOCT and you can very well see these microcysts and macrocysts, which will actually help you. And even if there is a suspicion of a nevus turning into a malignant lesion, you can actually see the change in the ASOCT where the cyst will stop abruptly at certain position and then it becomes more thicker and more without the cysts. Okay, so going on to the next case of the day. He's a very young patient. He was 28 years old and he comes with a pigmented lesion in the left eye, a diffuse pigmentation over here. I'm going to show you a closer picture. He does have a little bit of pigmentation over here too. This would be a complexion-associated melanosis, but then quite asymmetric. And this is how the lesion looked like. So this was one of the cases that I saw during my fellowship with Dr. Honavar. Very interesting case, quite scary looking. You can see how the extent of the lesion is. Do you want to try diagnose this? So we said in the quiz round that it's a malignant lesion, right? Yeah, very extensive. But do you find very typical features of malignancy here? No feeder vessels, right? No intrinsic vascularity. It is like bland black in color. Okay, so the chances of this being malignant is less. All right, but then we went ahead with the excision biopsy and reconstruction of the surface, and this is what we found. They were all naive benign cells but large cysts all around. So this came out to be pathologically as a giant balloon cystic nevus. So nevus can be small, nevus can be bilateral, nevus can be amelanotic, and nevus can be extensively large. Okay, so you need to look at the features that can, characteristic features that can differentiate it from malignant lesions. Well, so this is a 32-year-old male patient coming with this kind of small pigmentary lesion over here. It's actually a trivia case. He had these lesions bilaterally. I just got one eye picture. He works in a factory. Yeah, okay. He has such pigmented lesions all over the eyelid. Sorry? Blast injury, yes. Okay, so this is a blast injury. So he has all this over the eyelid, so you need to, evaluate it very well. So it was just a lesion in the conjunctiva. Obviously, when a blast happens, you close your eyes. So there are very less chances of that reaching into the conjunctiva, but more of it was distributed over the eyelids. So this is tarsal conjunctival lesion, a pigmented lesion sitting over here. I will tell you the history later, retrospectively. What do you think it could be? Foreign body, yes. Okay, yeah. So the bulbar conjunctiva, you don't miss the foreign body at all because you examine them. Most of the time, we always miss to avert the eyelid whenever a patient comes with complaints. So this was a case which was referred to me as a case of sebaceous gland carcinoma, in fact, okay, in the upper tarsal conjunctiva. So she had a history of foreign body fall in a temple visit 1 year back. Okay, yeah. And this was lying there in the tarsal conjunctiva, stuck there as a foreign body, leading on to a foreign body granuloma. Okay, so some foreign bodies can also give you a pigmented appearance. All right, yeah. So that has to be kept in mind. Yeah. Very faint pigmentation in the bulbar conjunctiva over here. Easy. Old patient, unilateral. All the clues are there. Primary acquired melanosis, all right? So usually the primary acquired melanosis, it is seen in middle-aged patients, unilateral, most common in the Caucasians. We do see them among the Asians also. It's usually in the bulbar conjunctiva, flat, patchy and multifocal. It gives kind of a cobblestone appearance on the surface, and there will be kind of microfolds over the surface which will help you to differentiate it between other lesions, and there will be absolutely no feeder vessels in primary acquired melanosis. So is primary acquired melanosis important? We have all known and we have all learned that primary acquired melanosis at one point can show atypia. And why is it important? If there is atypia in primary acquired melanosis, the chances of PAM turning into conjunctival melanoma is much, much higher. So it's very common among the Caucasians again, okay? But then the PAM turning into conjunctival melanoma among the Indians and the Asians is not as frequent as in the Caucasians. So a PAM in a Caucasian patient is very alarming in a clinical situation. So this is a paper which Dr. Shields and group had published, where they tried to kind of correlate and find the relative risk of PAM turning into a conjunctival melanoma, and this is what they have come up with. So they found out the increase in the claw cover. So what you see here is like 1 claw cover, 10 claw covers, and 12 claw covers. So depending upon the claw covers of extension of the PAM, there is a chance that 21 is the relative risk of this lesion turning into conjunctival melanoma. So that's when you go ahead and do a biopsy. So often you're confused whether a PAM should be excised, what should be done for a PAM. A smaller PAMs can be even done, a cryotherapy can be done over the surface, but if it's a larger PAM, you should always evaluate pathologically and find out whether it's a PAM with atypia or without atypia, which is very, very important. Now, what are the dangerous PAMs? So usually the PAM happens in the bulbar conjunctiva. Anything which occurs in an unusual site, like the tarsal conjunctiva, the phonacial conjunctiva, the caruncle, is again quite alarming. The chances of these turning into melanoma or this being a melanoma is also much, much higher. So these are the percentages that has been taken from various literatures. So a severe atypia in PAM, the chances of it turning into a conjunctival melanoma is as high as 32%, which is quite scary. All right. Yeah. Now going on to the conjunctival melanoma. So this is the malignant pigmented lesion. Why is it important? Because the prognosis in conjunctival melanoma as far as regional metastasis and systemic metastasis and mortality is quite high. So now we have these pre-conjunctival melanoma lesion, the pre-malignant lesions. PAM, 75% of conjunctival melanoma arises from PAM, 20% de novo, and even from a pre-existing nevus. So nevus is also considered as a pre-malignant lesion where the patient needs a constant follow-up of these lesions, all right? Yeah, so usually it's elevated, it's nodular, it's fleshy appearance. There will be a prominent tortuous feeder vessel. So feeder vessel is a characteristic feature in these lesions. There can be an amelanotic component to conjunctival melanoma also, all right? And the intrinsic vascularity that the lesion carries will also be very striking. It does have systemic association like dysplastic nevus syndrome. You need to search, ask the patient whether you have similar lesions in any other part of the body, neurofibromatosis, xeroderma pigmentosum. They can also be metastatic. right? A patient having a melanoma in another part of the body, they can have metastasis in the eye. So you need to ask for various other lesions in the body and also examine those lesions. So this is a melanoma, but you can see there is hardly any pigment. But if you closely have a look over here, there is a pigmentation here. So this is actually a conjunctival melanoma arising from a primary acquired melanosis. You can see how fleshy and thick it is, with lots of feeder vessels which it carries along with it, and the intrinsic vascularity over it. So primary acquired melanosis, as I told you, 75%. This is a case of primary acquired melanosis which was extending into the caruncle, and the caruncular area turned into a melanoma. De novo, 20%. You can see the characteristic thick, large feeder vessels over here. Conjunctival nevus, 5%. Okay, so this was a case where the patient initially started to have a nevus in the superior bulbar conjunctiva, later turning into a thick fleshy lesion, which was suspicious of a melanoma. We did a pathology and it was found to be conjunctival melanoma. So you can see the AIOCT, where this is the nevus part which abruptly stops over here, and then it becomes a fleshy area, as you can see here, UBM picture. All right, and pathologically, as you can see here, this is the nevus part and this is the nevus turning into the melanoma. You can see the demarcation from here. All these areas are nevus, but then suddenly it turns into a conjunctival melanoma. All right. Why is it very important? Why is it very, very important to differentiate these lesions? The regional metastasis rate with conjunctival melanoma is reported as high as 40%. Systemic metastasis as high as 25%. So what are the characteristic features that should be essential for you to kind of predict that this could be a melanoma, or the chances of metastasis? Thickness, any thickness more than 2 millimeters in size, a large basal diameter, nodularity, a nodular lesion, non-limbal location, margin positivity if you go for an excision biopsy, orbital extension of these lesions, and de novo origin is much worse than the other two melanomas, okay, rather than a PAM turning into a melanoma or a nevus turning into melanoma. Mortality is the other question. Very alarming. 32% at 15 years if you don't treat it well. All right, so it's very, very essential that you take care of these patients with conjunctival melanoma. So we do have the AJCC classification, as Dr. Vikas has already discussed regarding the OSSN and the squamous cell carcinoma of the conjunctiva. Well, so it's not difficult. It's depending upon the quadrant of location. So T1 is of the bulbar conjunctiva, but again, increase in the quadrants, you divide it into A, B, C, and D. Now T2 are those which is in the abnormal locations other than the bulbar conjunctiva, the palpebral, the fornical, and the caruncle. Again, depending upon the quadrants, it becomes A, B, C, D. Okay, T3 are those with local invasion. It could be of the globe, it could be of the eyelid, the orbit, or even the paranasal sinuses. And T4 obviously are those with intracranial extension. Depending upon the presence of nodes, we put it N0, N1, and again on the metastasis. So there has been various papers which has evaluated the validity of AJCC TNM classification in conjunctival melanoma, and we do follow. So this paper came up and they showed that T2 and T3 has significantly higher rates of local recurrence, regional lymph node metastasis, and distant metastasis. So AJCC TNM classification in conjunctival melanoma is useful. Whenever you have a lesion which is in the fornix, in the caruncle, you should always take an imaging in order to rule out orbital extension. All right. Yeah. Now, another thing which is no more controversial, it was considered controversial 2-3 years back, but now it has been proven that sentinel lymph node biopsy in these lesions is quite important. So this helps you to identify the first draining lymph node for the regional metastasis. So depending upon the thickness, the paper had shown that less than 2 millimeters in thickness in conjunctival melanoma, the chances of having a regional and systemic metastasis is around 5%. More than 2 millimeters, 18% in regional and systemic 30%. So yeah, 2 trivias. Pigmented lesion. I'd shown you this. We said it's like so-so here and there. Dr. Vikas knows the answer. What is this? keratin. Okay, so it's a keratin over the lesion over here. So it's a pigmented OSSN. Okay, so again in Asians you can have a pigmented variant of OSSN. So it is malignant. It's a squamous cell carcinoma, but it is pigmented with the presence of keratin. So look for these subtle signs. This one I showed you. We said it's a benign lesion. All right. What else can you see over here? Pigmentation of the iris. What could it be? It's an extraocular extension of a ciliary body melanoma. Okay, so these subtle signs you should look into. You have to do a dilated examination and look for a ciliary body lesion. Well, so this is another conjunctival melanoma which has got intraocular extension. So wide clinical spectrum, it is very essential to differentiate these malignant ones from benign and appropriate management, which Dr. Honavar is going to go ahead. Thank you so much. Thank you for your patient listening. Any questions from the audience? Or if you want to share your experience with any pigmented lesions. Yes, please go ahead. You need a mic.
You said you have to do the sentinel lymph node biopsy. Do you advise to do lymph node biopsy even though the lymph nodes are not significantly enlarged? Or only if it is enlarged?
So when clinically, we always palpate for the preauricular node, the submandibular, okay, and the anterior cervical nodes. If I feel there is a node palpable over there, whenever I take up the patient for surgery, I do a biopsy for the lymph nodes.
Even though it's small in size?
Well, if it is palpable, yeah. If it is like 1 millimeter size, we know it could be inflammatory also. But then with the lesion sitting there, you're always suspicious. So I also want to know whether it's inflammatory lymph node enlargement or a regional metastasis. So I would either go do an FNAC or a biopsy. Yes.
Thank you.
Yes. Any questions? No questions means you either understood everything or you did not understand anything. Yes? Yes, ma'am. Please go ahead.
The sentinel lymph node biopsy comes positive.
Yes. A radical neck dissection will be done by a head and neck surgeon. Yeah. So sentinel lymph node biopsy, I don't do it. Okay, so what we do is like we put it, I inject the technetium thing in the conjunctival cul-de-sac and then we send it to the head and neck surgeon. So they do have a gamma probe, then they go through the neck over there and then it will beep if there is an indication and then they open it up immediately. They take that node and then they kind of trace and do a radical neck dissection. Yes. Anything else? Over to you, Dr. Honavar. Thank you.